It's always an excellent opportunity to be able to represent your country, whether it's on the field or off the field. So to be a part of the Sydney Olympics and see all the athletes from the different countries makes me feel very proud that I was able to represent the U.S.
Growing up, basketball was my main love that I did, and I played that a lot. I had a basketball court growing up in my backyard. I didn't play a lot of competitive sports in high school besides basketball, but I was a very active kid.
It is my life. Dancing is my life. Dancing is like the freedom, it's expression of movement, it's an art form, and it's how I express myself. It's what I do. It's what I'm good at.
This world-class athlete, this sports writer, and this ballerina have something in common: painful injuries that are often part of a passion for sport.
My nickname is Frenchie. It was given to me by my college coach at the University of Portland, just based on my last name. As I started growing up, it kind of became clear that soccer was a sport that I was going to excel the most at. In college, I went to the University of Portland, played there all 4 years, and we went to 3 Final Fours, losing in quadruple overtime my senior year with 23 seconds left against the University of North Carolina. So, not that I remember anything, but professionally, I went on to play in the WSA, which was the Women's Professional League at the time. I started in Washington, D.C. with the Freedom, and then the next season I moved to the West Coast and played for the San Jose Cyber Rays.
For Michelle French, the highlight of her competitive career was capturing the silver medal at the 2000 Olympics.
You know, it's kind of funny to have won a silver medal. You would think, wow, that's amazing, that's awesome. But then you're like, wow, we were so close to winning the gold. And so everyone's like, yeah, but you have a silver medal, you know. And so it's tough to keep perspective when you're so close to getting, you know, a gold.
Okay, your left to the cone, pull it back with your right foot, push it with the outside of the left.
Michelle continues with her soccer nearly every day, either as a Washington youth soccer coach and camp director, or as a player with the Seattle Sounders. The Sounders are a women's semi-professional team, a group of top-caliber players who love to play the game.
The only time I've ever been injured playing soccer was when I tore my ACL and partially tore my meniscus and my MCL. And it was during a Seattle Sounders soccer game, and a girl was going to cross the ball. She cut it back. I planted to block it and ended up tearing my right ACL.
The ACL is the anterior cruciate ligament, one of the major supportive ligaments in the knee, connecting the lower leg bone, or tibia, and the thigh bone, or femur.
When I tore my ACL, most people had explained it to me as you would hear a pop, but I felt like I just heard a bone crack, and it was the most painful thing I've ever experienced.
Michelle went to the University of Washington Sports Medicine Clinic for an arthroscopic surgery, a procedure that uses miniature cameras and instruments to repair joint injuries in a minimally invasive fashion.
She came to our clinic after she'd torn her ACL, and she was pretty demoralized at the time. She's a very upbeat person, but I think she recognized this as being an injury that could really affect her ability to continue playing and coaching at the level that she was at.
I chose Dr. Wall because I had heard that he has more of an aggressive approach to surgery. I wanted to be able to get back out on the field as quickly as possible.
I want you to let your foot fall right into my hand.
Okay.
Okay? And I'm not going to drop it, I promise you. I'm not doing anything exciting here. Tell me when it starts to feel stiff and you want me to stop.
Okay.
In general, I try not to take too different an approach with either the weekend warrior or the elite athlete, because I think that athletics and activities are as important to the weekend warrior as they are to the person who's a high-level athlete. I try and treat them the same way. I essentially find out what their goals and what their hopes are, and as long as I don't think that those goals and hopes are in direct opposition to what's most healthy for their body and their knee or their shoulder, then we try and get them back to those levels.
The first thing we're going to do is harvest some hamstring tendons that we're going to use to reconstruct your ACL.
ACL reconstruction is a surgery where we actually substitute for the function of the original anterior cruciate ligament. When most anterior cruciate ligaments tear, they can't be repaired. So we take out the torn or damaged anterior cruciate ligament and we reconstruct or substitute with a graft or a donor tendon or ligament from elsewhere in the body usually. And frequently the tendons that we'll use for this are the hamstring tendons. There are 5 hamstrings that cross the knee. We can take 2 of them with relatively little, almost no perceptible deficit in strength or function.
Again, trim these up and get the muscle off of them.
Once the tendons to be grafted or removed, they're prepared on the back table in such a way that we place special sutures around them and place them into special devices that allow us to pass the graft into position and then secure it.
So this is going to be our graft once we're finished. There are 2 tendons and they're each doubled, so it'll be a 4-stranded graft to make it new check rein to hold the bones together.
Before we can reconstruct the anterior cruciate ligament graft, we have to prepare the sites where the ligament's going to begin and end in the knee. And this is done by using special equipment that allows us to shave away a bone, see the bony landmarks that tell us exactly where the graft should go.
So this is the posterior cruciate, which is normal. The anterior cruciate runs from here to back here, and that's where we're going to put our new graft. Now we're going to put the first tunnel into the joint.
Small tunnels are drilled into the tibial side of where the graft goes and also the femoral side. And these tunnels are drilled to the dimension of the graft. So once we have the graft and we know how big it is, we can drill the tunnel just big enough to admit this graft. And it basically forms a socket.
So now we're going to pull it through lengthwise.
The soft tissue from the graft is pulled into the socket and then secured there. And the beauty of this is that the body will heal the soft tissues to the bony socket.
And now we're going to just check and make sure that I can straighten the knee all the way and that everything is going to fit.
Once the graft is inserted, it has to be tensioned. So we take the knee through a full range of motion with the graft in place and make sure that we like the position of the tunnels where the graft was placed.
Because all we need to do now is fix this graft to the tibia, which we'll do with a screw and washer.
Once we get the graft at the tension that we like, we tie the sutures from the graft around a screw and washer, which is a post. Those metal devices don't dissolve, but they can be taken out later if the patient prefers to, although most patients don't. I think with Michelle, we really wanted to be pretty quick about getting the knee into the sort of a comfortable situation where we could perform surgery on it, get her surgery performed efficiently and appropriately, and then really concentrate on our range of motion strengthening and post-operative rehabilitation program with sort of an accelerated program to get her back at the same level as quickly as we could safely.
So bring your toes, come back up, and bring your toes a bit more forward.
During rehabilitation therapy, Michelle, like other patients, learned what exercises she needed to do to strengthen her knee and how quickly she could begin working out again.
The majority of knee patients we see are ACL, typically ACL reconstruction. So what we try to do with them is progress them to increase their range of motion, their functional capabilities such as gait and ambulation, as well as trying to progress them functionally towards basically if their goal is to get back to running, then we will slowly try to get their quad strength up, their hip strength, their stability and proprioception to the point where they can start to perform more functional activities.
During rehab, I think the one thing that helped me the most that came from the physical trainers was just kind of do as much as your knee's going to let you.
And hold down there, keep your belly tight, don't let your knee turn in.
Motivating a patient actually takes getting to know them, which is very valuable in a physical therapy setting because we do have about 45 minutes with most of our patients. So it takes getting to know what actually makes a person work better.
Having them tell me that it's the confidence that I have in my own knee is what helped me kind of push myself a little bit more. So I think it's more of a mental thing than anything, and I think that's one thing that I learned a lot from them. It's been 1.5 years now since I had the surgery, and I am, knock on wood, pain-free. I ran the Seattle Marathon without having any adverse effects on it. I played a full Sounders season, never having any problems. So, I mean, overall, I'd have to say it was a very successful surgery.
At the Sports Medicine Clinic, we provide a diagnosis of injuries. We provide evaluation and treatment for medical illnesses that are affecting people's ability to do their sports. We have physical therapists that treat and rehabilitate injuries and try to train people to get back to be able to perform at a high level and also as safely as possible. The surgeons provide arthroscopy of all the major joints, as well as other surgeries for fractures, for instance, or different orthopedic problems that come up.
And I'm going to bring this down.
The non-surgical services include diagnosis and then treatment and rehabilitation for essentially whatever is keeping somebody from being able to do what they want to do. What I find a lot in runners is that A problem in the hip not only will cause pain in their hip, but can also cause pain in their knee. Which is
Dr. John O'Kane is a primary care sports physician.
What do you do? I'm the only family practice doctor. I work here with a group of great orthopedic surgeons, and so I see the majority of the new patients who come in with undiagnosed sports problems. I see them make a diagnosis. If they require surgery, we refer them on to our orthopedic staff, and if they require rehabilitation, then we take care of that here in physical therapy.
Engage, pull it forward and in. Yes, yes.
A physical therapist would typically evaluate and treat patients accordingly depending upon their different diagnosis, with different various manual techniques as well as specific interventions as therapeutic activity and exercise.
We'll do that next. Okay.
My philosophy of patient care is basically to think about the patient first, and to think about more than just the injury of the patient, but more to think about the influences, both intrinsic and extrinsically, that might be affecting this patient. The relationship between the physical therapist and the physicians is very unique in this specific setting because they are right next door to us. So it provides us with the opportunity to be able to discuss certain patients that they see concordingly in order to provide more of a very well-rounded approach. And I feel that the patients really see that, and they appreciate that.
So squat back, remember, let your arms come out. There we go, and back up, and then let's turn.
Athletes can be injured at any age.
I think my youngest patient in the past 10 years was 8, and my oldest patient was 93, and she was skiing moguls at Sun Valley, and she had a lumbar compression fracture. So that is also one of the things I love about sports medicine, is we're not about a certain age, we're not about a certain person, we're really more about an attitude, and about trying to take healthy people who essentially have a bump in the road, keeping them from doing what they want to do and then getting them back.
All right, here we go. So 2 counts out, and heel forward, out, 2, and back, and 1.
Riley Bell started dancing when she was 3 years old.
My parents actually put me in it, but they put me in dance because when I was little, I used to always walk around the house on my tiptoes. I'd wander around and I'd shut the drawers for my mom in the house and stuff. And so they were like, well, if she's dancing already, we might as well put her in and get her some training.
Really think of lengthening your legs.
What I like about ballet is that I really am able to express myself. It's a lyrical movement that just everything in the day that I feel, it's able to come out in my dancing. When I was dancing in Swan Lake, it's something that as the ballet mistress here puts it, it's truly a glorious feeling. There is 2,000 or 3,000 people watching me. I'm in a white tutu. This is the highest aspect of dancing. It's amazing. You are a white swan. About a year ago, I had a stress reaction in my second metatarsal on my left foot.
A stress reaction is one step below a stress fracture. The foot bone is not yet fractured, but it's close to being fractured, and it's very painful.
When I first felt it, I was like, ooh, this is not good. But I tried to make it work. I tried to do some remedies at home, and then once I realized that it was not getting any better, I decided to go see Dr. Cadle and take some time off.
Riley is a lovely dancer that I've known for many years. I first saw her when she was baby ballerina, I would call it, when she was probably 12.
And up, up, out.
I've seen her over the years. She's had a few episodes of stress fractures or near stress fractures, which are common in dancers. And through help with physical therapy, we're able to find some very subtle alignment things that she's been able to correct, and she's been much healthier since she's been able to do that. And I didn't have to do any surgery on her, which is really my goal with dancers, is to get them well without having to do any surgery.
Hi.
Hi, Nancy Cadle here.
Shannon.
Nice
Hi, Shannon.
you.
So you have some pain in your legs?
Dr. Nancy Cadle is a foot and ankle specialist who performs both surgical and non-surgical remedies. But she's also been a professional dancer and is a current dance instructor, which gives her the expertise to practice dance medicine.
Dance medicine is specialty care for the dancer, which includes diagnosis and treatment. but really geared toward a dancer and what their specific requirements of their art and sport are and how that might change our treatment. What is unique is the art and sport of dance, because dancers truly are athletes, yet they're also artists. And often the choreography requires very fine motor control, very specific either hand gestures or an emotional content at the same time that they're doing big motor jump, spin around in the air and land in a certain position. And I realize that if I put them in a cast and their ankle becomes kind of stiff, that could be a real problem for them if they can't point their foot as well as they were before. With this, your standing leg, tendu out to the side.
Being a dancer herself, Dr. Cadle is amazing with dancers because she's able to understand, like, when I tell her, it doesn't really hurt to do a tendu, but it hurts to roll through and come back in a tendu. It hurts to relevé, but it doesn't hurt to go all the way up on point. Like, she understands the terminology, whereas no one else does.
If they have some slight technical error, that can really exacerbate a problem because of the strange positions, strange to us lay people, strange positions that they use. So if I can assess their alignment and see that they have some asymmetry, that may be causing an injury. So they could have an injury in the ankle, but in fact, we may need to look at their hips or their back. It's not always necessarily just the ankle.
Mildred, let's go. We decided to treat my stress reaction with about 2 weeks of rest from ballet, no dancing whatsoever. She decided that I could be in a boot if I needed to limit movement, but she said that if it didn't hurt at all when I was walking, that I could wear tennis shoes, just very, very supportive tennis shoes. And I was supposed to ice it, do contrast baths, which are like put your foot in hot water for 4 minutes, put it in a bucket of ice water for 1 minute. Do that alternately for about 20 minutes. Very painful, by the way.
I feel a bit like a friend or a mentor to her in a way. And I love watching her dance. She's a beautiful dancer. And she reminds me when I watch her dance the passion that I would feel when I was dancing.
Dr. Cadle is more my friend than she is my doctor, I think. She is one of the warmest and nicest people I have ever met. Both of my parents, whenever they have gone in with me, they just come out and go, "Oh my goodness, she's just so wonderful." She's not afraid to give her opinion. She's a great person. Good girl.
Naturally, the University of Washington Sports Medicine Clinic also takes care of UW athletes.
We have 23 sports and about 600 to 700 athletes here at the University of Washington who are part of our practice. And there are several of us who do that, and my particular responsibilities are to take care of the orthopedic aspects of care for the football team and for the men's basketball team. The duties that are entailed in that are treating injuries as they occur, but also covering events. And so I am at all of the Husky home basketball games and at all of the Husky home football games, as well as a good portion of those on the road.
Being a team physician for the Huskies is a great honor, and it's really a lot of fun. They're a great group of students. I take care of women's soccer, men and women's crew, men and women's cross country, and men and women's track.
I'm the chief of the Sports Medicine Clinic. I take care of Husky athletes, and predominantly that's football players, women's basketball players, men's soccer, and men's baseball.
The most enjoyable part of my job, taking care of patients, is probably taking care of the Husky athletes. And the reason is that I don't only see them when they're having a problem and in their early phase of rehabilitation. We see them when they're down, when they have an injury, when they have a problem. We take them through their rehabilitation, but then we also attend their games, and so we get to see them get back out on the field and end up being successful beyond their injury, and that's really exciting.
I did a shoulder procedure in our star forward, Mike Jensen, about a year and a half ago, right before his senior season, he dislocated his shoulder, and we were able to get him back to play his senior season.
One thing I like about being a surgeon is that you can intervene in the appropriate situations and make a fairly quick improvement in somebody's condition. If there's some abnormal anatomy, a loose body within the joint, a torn cartilage, it's something that you can go in and within one day solve that problem, and then with appropriate rehabilitation return a person back to the level that they were before their injury.
Yeah, try to keep that knee over the toe as much as you can.
So the injury in your knee is to the medial meniscus. The term sports medicine is a relatively new term, but it's treating athletes at all levels, not just high-level professional or collegiate athletes, but everyday athletes. Anyone who really wants to remain active and participate in exercise and sports, we would consider that a part of sports medicine.
You may have had a little bit of the joint lining, the synovium, that folded in between the bones and got caught, and that's like, you know, very exquisite, horrible pain. And then one of the things that makes sports medicine unique is it's kind of like a Nancy Drew novel where you have a mystery that you're trying to solve, because in sports we're returning the patient to the scene of the crime, and they're going to go back and do exactly what they did before. If we can't figure out why they got injured, then chances are they're going to get injured again. So that's part of what makes it fun, is to figure out the mystery, solve the mystery.
What I really like about basketball is just the constant flow and just the constant energy that it brings. And it's a team sport too. You know, you get to play with other people, you get to pass them the ball, and it's just something I really enjoy.
It's not often that Bill Christensen can get out on the basketball court, or do many active things for that matter, because he has a serious problem with his shoulder.
Essentially, the nature of my injury is my shoulder keeps popping out easily. You know, it's just it doesn't stay in there. It's not stable, you know, and any small movement or reaching or anything like that makes it pop out, and it's highly painful when your shoulder's out of place. Oh yes, this is so gourmet. My shoulder's popped out about 6 times. I mean, I'm starting to lose count. The sensation is extreme pain. I don't know how else to describe it. This surgery is something that I definitely need to get done so I can continue to be more active or go back to being active.
Why don't you come on over to the monitor here and let's take another look at your MRI.
Okay.
Bill was referred to Dr. John Green by his primary care physician.
Anyone whose shoulder dislocates several times, we generally recommend a surgical repair. Oftentimes those dislocations are caused by labral tears in the shoulder, and so repairing that labrum is a procedure that we can perform arthroscopically. So just relax the arm.
Okay. Dr. Green, he's a very open doctor. He's very clear and concise, and he puts it into terms that I understand, so I don't feel fearful or uneducated about what's actually going to happen.
How about if we bend it like this? I played football for the University of Cincinnati. I also had shoulder dislocation troubles myself, and so I had shoulder surgery. I understand what it's like to be out of action and unable to participate with the rest of my teammates. I understand what it's like to go through a pretty grueling rehabilitation process and get back to full activities. Well, I'll see you on Friday.
All right, see ya. Thank you very much.
Outstanding.
My thoughts are, bring it on. You know, I want to get this going and get it over with. I want to start the rehab. I want to be back on my feet.
Okay, so I'd say for the nature of your surgery, there's a couple elements we'll talk about here. So,
3 days later, Bill is at the UW Medical Center Surgery Pavilion for his arthroscopic shoulder surgery.
An arthroscopic labral repair is an arthroscopic procedure where we'll get the labrum back to a normal position and secure it there with absorbable anchors so the body can heal it back so it'll work normally to keep the ball from rolling out of the socket. Good afternoon, Bill.
How you doing?
Typically, Dr. Green will perform between 4 and 5 surgeries on a surgical day in both knee and shoulder arthroscopy.
I'm ready. I'm all warmed up. Today I'm actually doing 1 knee arthroscopy, 1 hip arthroscopy, and 2 shoulder arthroscopies. Okay, so let's have the shaver, please. So to do the labral repair, first thing I'm going to do is scrape the labrum off the socket. So It's actually stuck down on the front of the sock and it needs to go right up on the top. There's the labrum right there. It's been a long time since it's been up on the rim. This is where it belongs. The next step will be putting in some anchors in the bone. How about right there? So I'm holding the guide. Dr. Wilcox is going to drill the hole here. An anchor is just an absorbable little device that allows me to sew things directly to the bone, and it's more convenient than passing the suture through the bone itself. So I'll use an anchor, then put a stitch into the labrum and start sewing it back down to the socket until the labrum is reapproximated to its normal anatomic position. At the same time, the way I'll put the sutures in will tighten up the ligaments a bit as well in the shoulder. This is the middle glenohumeral ligament right here. You can see how it's actually been tightened by what we've done here by bringing all this stuff back up. The important part of this surgery is to actually get that labrum back up where it belongs. Okay, we're finished. I think the best thing about being a surgeon is being able to repair folks that are broken. It's very gratifying to have a young man who's dislocating his shoulder because his labrum's in the wrong spot, and we're going to be able to put that back in the right spot, let him heal it up, and after the rehabilitation process, get him back to his usual activities.
Sports medicine and arthroscopic surgery aren't just limited to athletes.
We actually see anybody who's active, who's having problems with their current activity, or who wants to do a new activity and is worried about how to do it without getting hurt.
And that helps people to participate in the activities they love.
You just get so into it and you're just like, this is what I'm doing, and this is what it's all about. This is the fun part.
Without soccer, I don't really know where I would be right now. The people that I know, the friendships and the relationships that I have are all based on soccer, my playing career, my coaching career.
Our goal at the Sports Medicine Clinic is to take people who are active and have had an injury and are unable to do the sports or the activities that are important to them. I describe that as their athletic identity, the thing that really makes them feel complete or whole or who they are. And when they can't participate in that sport or that activity, they lose something that's very precious to them. And so I really feel like it's our job to try to get them back out there onto the field so they can regain that identity.